like I said, airway is the most important thing. ABCs, airway, breathing, circulation. We'll walk through that a little bit as we get going. And then we'll learn some airway adjuncts. What's an adjunct? You may know what an adjunct is. Adjunct professor. It's a helper, something that helps. So we're going to have different devices and different helpers that's going to help manage the patient's airway. Once we determine that their airway is open, breathing and circulation is intact. If they're not breathing, is that a huge problem? Is the patient's not breathing?
Yes.
How many people say that's a problem? That's a huge problem, the patient's not breathing. How many want to be right in their answer and say, that's really not a problem because, I'm going to fill in the blank for me, it's really not a problem that you're not breathing because, let me help you out. You still have a pulse, yeah? If you didn't have a pulse, would that be a problem? Yeah, that would be more problematic. But not a huge problem. Same way with the breathing. If you're not breathing, it's not a problem because I'm going to breathe for you. Right? So you're breathing. When you look at the ABCs, when you look at this, break this down, we've got to sort of do this right quick because some of this may not make a lot of sense to you. So you have the ABCs, airway, breathing, and circulation. When you say airway, you want to make sure that the patient has a patent or open airway. Means that they can get air from atmospheric air into their lungs. They have an open passage to get there. So we'll show you that in a few minutes. The next thing you want to do is to make sure that they're breathing, that they have adequate rise and fall of the chest, that you can feel air coming out. And then the third thing that you want to do is circulation. You check a pulse. What pulse is this? Radial pulse. If they're unconscious, then you would check a carotid pulse. Again, CPR time, we'll hit all that. And then that's your ABCs. And these essentially take, if they're conscious, it only takes like 3 seconds, if that much. Because if I was going to check the ABCs for you, I would come up and say, hey, how you doing? And he'd say, well, good. All right? Boom, ABC's done. He has an open airway because he spoke. He made a very low sound, but he did make sound, okay? So he spoke to you. So A and B are done. You can't speak if you don't have an open airway or a patent airway. And if you're not breathing, you can't speak, right? So that's done. And you notice I reached up and touched his radial pulse. So he has a pulse. So ABCs are done. Everybody good with that? The thing that you have to remember is that you can't go on to B without fixing A. So each one of these ABCs you have to fix before you go on to the next one. Not fix forever, but take care of. So if they have an open airway, you open their airway, and they have a patent or open airway, but they're not breathing, then you breathe for them. You fix that. You're breathing for them. They're breathing. So then you would check a pulse. And if they don't have a pulse, then you would start CPR. But that's for another day. Right? So you see how that works, that ABC stuff works? Any questions there? Very important that we remember those steps. We're continuously build upon that. This stuff here is just review from the other day, the upper airway. That's why I gave you that bigger handout that I promised, because so you can see the bits and pieces of the upper airway. The upper airway begins at the mouth of the nose. Remember the nasal airway or the oral airway. In the nose, the air is warmed and humidified because it's dry through the nasal turbinates. Because adults are nose breathers. So it's warmed and dried through the nasal turbinates. When we get down to the pharynx with the oro, see the prefix on that? Anytime that you see that, that would be oral, mouth. Pharynx, the throat, is what we would call the pharynx. Naso, see how nasopharynx. Laryngopharynx, where would that be? Yeah, the larynx, right here. So and it ends at the glottic opening. Why is this called the glottic opening? Very good. The epiglottis is typically right there on top of it. So you have the glottic opening, so where the epiglottis is, essentially. So below the epiglottis, it would be considered the lower airway. So in the picture, you have the nasal passages, the nasal turbinates forms the air comes down into the pharynx, or the oropharynx, and then goes down into the pharynx, and then into the hypopharynx, which is just right above the epiglottis. The epiglottis opens, and then air goes down into the trachea. Once air passages, I'm having a stroke, passes the epiglottis, or the glottic opening, then you begin into the lower airway. So it goes through the epiglottis, through the vocal cords. Keep that in mind, the two vocal cords. Like my vocal cords right now are just like vibrating like crazy, right? Because that's what makes sound, the vibration of those vocal cords. If something is stuck between those vocal cords, can you make any noise? No, because you're right. You can't make noise because they won't vibrate. They're held shut. Then it goes down to the trachea, about 21 centimeters long. It bifurcates at the what? The carina into the right and left bronchus, down into the bronchial passages, all those smaller and smaller bronchioles, and ends up at the alveoli. And then this is sort of the way that we look at the picture of the trachea here. In CPR, we'll talk about this, the larynx, and this structure right here through the larynx, because we'll be talking about holding cricoid pressure. It's being outdated. They're trying to change this cricoid pressure, but everybody that's from the older school still uses cric pressure, so we'll talk about that. You notice as the trachea comes down, it has these circle C-type rings of cartilage to it, and that's to hold the trachea upright. The esophagus, which is posterior, is not held upright. There's no cartilage in there. And then comes down at the carina, bifurcates there, and then into the bronchioles. Remember, the alveoli are the really small, tiny air sacs, sort of grate-like ends to the airway. They're completely surrounded by pulmonary capillaries, where the diffusion takes place. Oxygen and carbon dioxide diffuses through this. And I just relearned the other day, I want to make this sort of thing about relearning stuff. I mean, I've been doing this for medicine for 20 years, right? And I relearned something yesterday that I'd forgotten. Isn't that? So that shows you that you're never, as long as you stay in this, you always learn or relearn. Every time I go to the hospital with you guys, most of the time I learn something. I'm as active as you guys are. I'm like a kid in a candy store. I'm going around checking things out. You know, so it's never really too late to learn stuff. What I relearn is carbon dioxide. Oxygen is a gas, so is carbon dioxide, and it's diffused through water. It's diffused through, there's fluid between the alveolus and the capillary system called interstitial fluid, fluid between the cells. and it diffuses through that fluid. Not a huge thing, but something just to remember, that it diffuses through that fluid. You have this gas that moves through this fluid. Later, it will make more sense, because when we talk about a patient with congestive heart failure, their lungs, if they have left-sided failure, their lungs could be full of fluid. So it adds fluid in that space, and it makes that space from here, which is diffusion can take place, to a wider area of fluid where diffusion can take place. It can't go through that much water or that much fluid. So that's going to clear that up when you know that this oxygen and this carbon dioxide, once it's rejoined together, has to go through this fluid to diffuse. Makes a lot of sense for us. All right, let's watch this short video on this gas exchange. Maybe not.
Involves several events, including breathing. As we zoom into the body, we can observe the respiratory system during gas exchange. Air passes through the alveolar sacs to the alveoli, where gas exchange occurs. In this cutaway view of an alveolar sac and its capillary bed, the process of gas exchange is easily observed. During inspiration, atmosphere air fills the alveoli, and gas exchange occurs between the alveolar and capillary epithelia. Oxygen in inspired air is represented as a white gas. Carbon dioxide in expired air is represented as a blue gas. Notice the change in color in the red blood cells during gas exchange. Now, let's zoom into a higher magnification view of gas exchange at the respiratory membrane. Red blood cells in the capillary adjacent to the alveolus release carbon dioxide and bind oxygen.
All right, a quick little movie on just a gas exchange. I wanted to make sure that you had that sort of pictorial reference of this moving back and forth. Me waving my hands up here like I'm having some sort of seizure probably doesn't really do it. But that gives you a good reference on how this gas moves out of the alveolus into the capillary. All right? We will build on this because of the fact that in respiratory physiology, when we get into that, like I've told you before, if you know cardiac and respiratory, you know a lot about what's taking place in the body. So that's why we focus on those two systems. And I think that will help. We will build on this basic concept, just like math. We start out A plus B equals C, right? Is that true? I just sort of made that up. I don't really know. But 2 plus 2 is still 4, right? Okay. So we build on that, and then we get into these weird math problems with imaginary numbers. All right, well, let's look at some pathophysiology. Some airway obstructions, we'll get more into CPR when we start doing CPR. You have foreign bodies in there. You have food, toys, little kids, they're explorers. They pick up things with their hands. They automatically put it in their mouth. You have things we'll get into suctioning, where blood and vomitus in the mouth. It just maybe a lot of secretions. Anything that prevents air from in the atmosphere going into the lungs is a airway obstruction. You have a mild obstruction, which would be something maybe like vomitus or blood back there that's sort of gurgling in there, or a full body airway obstruction like the tongue on an unconscious person, or a toy that a little kid has swallowed, right? So you have a variety of those. They can be acute, which is sudden in onset, or chronic, chrono, over a long period of time. You have someone with throat cancer, and they continue to build up problems in their throat. and then they all of a sudden they have to have a tracheotomy because they have an airway obstruction. So what we want to do is always evaluate, make sure that the patient always has an open airway. The acute things that we look at, again, someone vomiting. When we talk about vomiting in class, that equates to airway obstruction. The same way when we talk about blood, we're talking about right now, we're talking about pressure, okay? And then we're also talking about oxygen delivery. So when we talk about those two things, vomitus or anything like that, we talk about airway obstruction. And then over a period of time, you get edema. Edema is what? Anybody know what that word means? You're right. No, fluid. Fluid. Edema is fluid or swelling. So you get edema over a period of time. Allergic reactions. People have allergic reactions to bees or peanuts or whatever. Their throat begins to swell. And also decreasing mental status. When that happens, the tongue becomes more flaccid. In other ways, we have bronchoconstriction, like in COPD, like in asthma or emphysema that we'll speak of. So we get into more of the lower airway that constricts the diameter of the bronchiole. So airway constriction or blockage in the lower airway deals with how big or small that the bronchioles get. And usually it's a constriction, like in asthma, bronchial constriction. One of the problems with asthmatics is their bronchioles constrict and they can't get air out. They can get air in, they can't get air out. So we'll speak of all these in a few weeks.
You said that chronic is over a long period of time, but and acute is what?
Sudden onset.
Okay, thank you.
And when you say acute, if you have to sort of break it down, it could be anywhere from like right now to 3 or 4 hours. It's still acute in medical terms. All right, so when we look at the airway, we assess the airway. So we're making an assessment of the airway. We have to say, is it open or patent? Patent is the medical term for the airway to be open. I usually don't use that a lot. Once you guys figure out the terms, I just say that is the airway open. It's easier, but the medical term is patent. And will it stay open? Huge, important question. If you have a patient with a decreased level of consciousness, are they going to be able to maintain their own airway, or are you going to have to do something to fix it? See, now we're beginning. We're taking these steps and actually getting into more of a doing thing. I mean, there's still a lot of memorization, a lot of learning, but now we're easing into that. I've got to do something. I've got to touch the patient, right? I've got to save a life here. So this is what we're easing into. So we do that assessment. Do they have an open airway? Will it stay open? Or do I need to do something to it to keep it open? And this is what we'll learn in the airway management. There'll be different skills that we can do to open their airway. The primary method of opening the airway is the head tilt chin lift. So you tilt their head back like this, and it mechanically opens their airway for us. Later I'll show you a device, another adjunct, called an oral airway that you stick in the mouth and it pulls the tongue off. That way you don't have to worry about it. Also, I'll show you another device called a nasal airway that you put in the nose so you can have a patent or open airway to hear. Constant consideration about the airway. It doesn't matter what is taking place with the patient. If they don't have an open airway, they're still going to die, right? So you have to make sure that the airway is open or patent airway. So when we look at these obstructions, a complete blockage of the airway is the inability to make noise or speak. They can't speak to you. They can't make any noise. There's something stuck in the vocal cords. They get this sort of raspy or stridor voice to them. A snoring respiration is they're making noise, they're snoring. It's like, right? That means a partial blockage of that airway because there's still noise coming back and forth. Or a gurgling sound. What do you think gurgling would equate to? Fluid. Good. Who said fluid? That's good. Fluid. Or drowning. They're drowning in their own fluid, but fluid. They have fluid in their airway. They're making this gurgling sound. Nobody has a straw, right? A drink with a straw in it. Okay.
You know his name.
I got to be more prepared. Maybe next time. They make this gurgling sound in there. So we look at the inadequate airway. Is there a foreign body? Can we not see or feel good air exchange? There's not good movement of the chest wall. Remember, the norm is symmetrical rise and fall of the chest. Good air movement at a regular rate. Maybe they're having trouble breathing and they're trying to do belly breathe on us. In an adult, abdominal breathing is using that accessory muscle that we spoke of last time. Or they having retractions in the pediatric patient. Neck tugging, nasal flaring, we spoke of that. All right. I must have deleted my picture of the